Good morning, everyone. A phakic intraocular lens is an artificial lens planted in the anterior or posterior chamber of the eye in the presence of a natural crystalline lens. It is used to correct refractive errors, especially in thin corneas where laser correction is not possible. I'm presenting a case of a 24-year-old female presented with pain, redness, watering in the right eye since 1 year, blurring of vision in the right eye since 1 year. She underwent right eye ICL surgery 1 year back and gives history of no improvement of vision and redness, watering, and 2 episodes of vomiting on the first post-operative day. She gives history of using glasses since 15 years. Her visual acuity in right eye was 6 by 36, not improving with glasses, and in left eye it was 2 by 60, improving with correction to 6 by 6. The intraocular pressure in right eye measured with applanation tonometry was about 32 mm of Hg, and gonioscopy revealed peripheral anterior synechiae in 3 angles. Right eye anterior segment examination had mild ciliary congestion. Cornea revealed few epithelial bullae with stromal edema. There were peripheral anterior synechiae in superior, inferior, and nasal quadrants, and iris had atrophic patches present more inferiorly. PI was present at 11 o'clock, it was patent, and phakic IOL was present. Left eye was normal with the PI at 2 o'clock. Fundus examination was normal. Right eye ASOCT showed a vault of about 890 microns, which was a high vault. Anterior segment OCT also revealed pass in 3 quadrants with central corneal thickness of about 600 microns. Specular showed a decreased endothelial count of 926 in the right eye. UBM revealed pass and anterior bowing of the iris. So patient was diagnosed to have decompensated cornea with synechial angle closure glaucoma, status post IPCL surgery. She was started on anti-glaucoma medications. At 4 months follow-up, the intraocular pressure was maintained, but there was worsening of stromal edema. So surgical plan was done. She underwent Descemet stripping endothelial keratoplasty with synovial lysis, IPCL explantation, and with phacoemulsification and foldable IOL implantation. 1 week post-op, her visual acuity was 1 by 60, with pressures were 16 mm of Hg by toner pen. The DSEC graft was in C2 with mild edema. 2 months later, visual acuity improved to 6 by 36. Intraocular pressure by toner pen was 13 mm of Hg. The DSEC graft was in C2, clear, graft interface was clear, and host cornea had mild edema. So in this case, patient underwent a complicated IPCL surgery. Most likely cause was toxic anterior segment syndrome, and high vault was also an additional factor which caused worsening of the condition. So usually the chances of TAS following ICL are very low as compared to cataract surgery plus IOL. Very handful of cases have been reported as ICL surgery takes lesser surgical time, lesser steps, and lesser entry of toxic substances. Patients coming for refractive surgery have very high expectations, and occurrence of a TAS can be can create a difficult situation. So some points to prevent PAS are cleaning, sterilization of all instruments, using intracameral ducts without preservatives, using fresh OVDs. The tips of lens and instruments should not be touched, and it is better to use powder-free gloves. So detailed preoperative evaluation should be done before selecting patients for phakic IOLs. Early suspicion and aggressive steroid treatment can prevent sequelae of TAS. Thank you.
Thank you. In fact, TAS is a major problem, and you are right. With ICL, the incidence is very low, but when it occurs, you have to treat it aggressively, because refractive patients, the vision was 6/6 and corrected, right? So anything less than that is not acceptable to the patient.